All right, so we are in week 7, and this is MN669. I'm going to do my journal. So describe a new experience, significant event, patient interaction never seen before, or diagnoses, etc., that you have experienced in clinical this week. So the kiddo I did my SOAP note on is diagnosed with ADHD. He's a 15-year-old male, and it was kind of wishy-washy on exactly what happened, but he reports and mom reports that he was being bullied at school, and as a result he gets very angry and wants to get aggressive. So he says that he got up and left the classroom so that he would not hurt him physically. Well, unfortunately, that was not the only thing that he reports he did. He got on Snapchat and made a post that he wishes he would have put a screwdriver in that the person that was bullying him in his ear, and then he said his eye. Put it on social media. It got to administration, and this is where it kind of gets wishy-washy. Mom says that he does report having those thoughts, but him getting up and leaving was a huge accomplishment, because usually he gets into like a physical altercation, and it had been like 4 years since that had happened. So since he was 11, he had been able to get up and just remove himself from the environment. And the part that mom was upset about was that they used the social media as a threat, and he had a means, he could get the screwdriver. He knew where this child lived. And mom was like, yeah, but this, that part is not okay. And that they didn't, praise him for the coping part of getting up and leaving. They ended up calling the crisis mobile team, which then assessed him and determined that it would be beneficial for him to be in an inpatient psychiatric setting because of the threats of harm to others. So he ended up being there for a week. They changed his fluoxetine to sertraline, 75 milligrams. This was approximately 3 weeks ago. So my preceptor is going to get the office to obtain those records so that they can be reviewed, because it wasn't like a follow-up visit after a hospital inpatient. It was a regular routine visit. And so, it was kind of like, oh, if we would have known, we probably would have had this information prior. But anyhow, long story short, we're going to continue the sertraline because it's been the 3 weeks. He says that he feels better, but still feels like he's not being heard at school. He's being homeschooled now. He had been suspended for the rest of the year. And mom, they're on an AEP, I believe it's called. So the teacher goes to the home, and mom is like, I think he does better, but that social interaction is still missing. And I totally understand as a mom, like, what else can we do? And so it feels like mom, family, they're all pretty much involved with him. And the next plan is, as he's getting or feeling recuperated, getting back on meds, that he feels like, okay, I feel like myself again, maybe start integrating back into school and speaking with the school system. And she had asked for a letter when that time comes from my preceptor, and he's like, totally, if I could see, changes in his coping, then we can look into that at that point in time, which is kind of cool, because I've seen the therapist preceptor also write notes to the school, and things seem to happen a little faster and better when they see a medical or psychiatric recommendation. So so this one was pretty cool. He also agreed to do psychotherapy. He had CBT when he was younger. And the family also was involved in the therapy, and mom was like, I think that's an excellent idea. I think we need to go back and just maybe learn new techniques or refresh ourselves, because mom's like, it's frustrating with the system. They don't understand. But there's no changes in his concentration. He's still maintaining an AB average. He says his ADHD is not the problem, it's the environment. And he's like, I know, something like he said, I know that I'm the crazy one, but just because I'm crazy doesn't mean it's right what they do to me. And it hit home. It's like, yeah, there is no labeling, and crazy mental health doesn't make you the villain. Anyhow, psychotherapy was agreed upon. They're going to start it next week. We're going to get the inpatient information so that we can review it for his next follow-up appointment in 2 weeks. I won't be there though. This is it for me, so I'm totally excited. I can't believe it's over. Let's see. So, discuss the impact this had on you in terms of increasing your understanding of the NP role, psychopathology, and or provider-patient relationship. This was definitely a therapy visit. It did take a lot longer to finish it because we had to get the information. We looked up the prescriptions that were sent to the pharmacy to confirm, and that was done. And my preceptor went into some of the billing, took notes. He said, as long as we spend 40 minutes before, during, or after the visit, then we can document 99215 rather than 99214. And then we can add the add-on of 90833. And then he also talked about like the co-pays, and some insurances don't cover it. Don't cover the 90833 psychotherapy part, and they'll be billed for the entire psychotherapy. And so it's, he kind of went into like knowing, not to put more financial burden on the patient, but still getting the time that we've spent and revenue that we've spent with the patient. So that was really cool. Explore personal strengths and limitations that affect the provider-patient relationships. My strengths are, I love adolescents. I've done it. So, listening is the biggest part. They just want to be listened to. They want, somebody to just hear them, really not necessarily agree with them if there's nothing to agree with, but hey, just listen. And then limitations, I find with ADHD, I look at the DSM-5 and I'm like, well, what would be differential? Is it defiance? Is it, and then I have to go back and really like look at it. And so, it's like in this case, is it defiance? Was it really what they're stating that happened? So I'm would have been anxious to see what the inpatient report said and the crisis center assessment. So I guess the limitations are the differential diagnoses. Sometimes I find myself like, but I did get a good hint from my preceptor is like, what diagnoses will be one thing off of a behavior. So like 6 months versus 1 year, or aggression versus anxiety. What does that mean? Like, as time goes by and you're using them, you'll be like, I think I need more time to know, is this really this? Which is kind of cool. Include reflection on your therapeutic use of self, and your discussion should reflect specific learning insight. Use of self. I like doing these videos, self-reflection, listening to myself, picking up cues on, what am I being passionate about? What do I need to kind of like dig more in? What am I comfortable with as far as diagnoses and meds and how they work? That's still like, and if you know the side effects, you know how to treat the patient. So changing him from the fluoxetine to the sertraline, the mom did not say why. She said there was no reported side effects from the fluoxetine, other than they felt that maybe a change in an antidepressant might help with the thoughts of sadness because of the bullying. you know, my preceptor was like, we can try it, but the the core element here is the bullying. Is this true? And if it is true, if he's dealt with it and has, his coping mechanism is to get up and leave, then we praise him for that. But then therapy can help with, well, why did you have to post on social media the harm that you would cause to someone? So, therapeutic use of self is remembering that therapy is such a huge part in medication management, and remembering my what causes the side effects, why we change a medication, do we change it abruptly, just going back and relearning, because sometimes I feel like in clinical or just as a floor nurse, we get into that routine and then we forget the basic things that they're so big. So reminding myself that, the patient needs time and I need time to go back and just gather my thoughts. So yeah, week 7.